Hi, thank you guys for coming today. So I'll start by talking a little bit about my background. So I am from the University of Kentucky, as you can see on my slides, and I was actually born and raised in Kentucky as well. I went to undergraduate at Murray State University, which is in the western part of Kentucky, and there I got my bachelor's degree in mathematics and statistics. After that, I went to Boston University and I got my master's in biostatistics. And I was all but dissertation for a PhD in biostatistics at Boston University. So what happened? So actually, I was in a joint MA PhD program there at BU. And I had finished all my coursework. I had taken my comprehensive exams, my qualifying exams, and I'd been in dissertation phase for about a year and a half. And I was on, I think, like my third different dissertation project and had made absolutely no progress because my advisor just kept changing her mind of what she wanted me to do. And so we had been kind of like working on this project. And in statistics, there are kind of like two large schools of thought. There are frequentist methods and there are Bayesian methods. And so I had done this paper that used kind of like a novel technique in a frequentist framework. And so now we had decided for my dissertation, I was going to figure out a Bayesian way to do this same thing. And so I simulated data. So like I knew what the answer to the question was. Like I knew what the program should return me. This is what the answer is, right? And even in very simple toy examples, the Bayesian method worked maybe 5% of the time. So it was just like not working at all. And I was so stressed. I was not sleeping. I was not eating. And so I went to my advisor and I said, hey, can you help me with this? Like, can you look at my code? Like maybe I'm missing something, that's like making this not work. And she said, no, it's your project. You're going to figure it out. And so thankfully I was seeing a therapist at the time and I had just gotten married. And so my therapist and my new husband ganged up on me and they said, you are not well. You cannot continue this way. I was having breakdowns like every night. It was bad. Okay. And so then they said, you need to at least take a leave of absence. And I said, okay. So it was like early June, and I went and I talked to my advisor and I said, okay, I need to take a step back. I'm mentally unwell. I'm going to take this summer. I'm going to focus on my mental health. And then I'm going to come back in the fall. I'm going to be re-energized. We're going to pick this up and I'm going to finish my dissertation. And instead of being supportive, my advisor yelled at me for an hour. She told me that I was crazy. I had all my priorities out of alignment. I think there was some line about like more concerned with your MRS than your PhD, which was like really fun considering I had just gotten married. That I would never be successful, never get a job. It was awful. Okay. Right. And so then I was like, okay, well, I'm still going to take some time. And so then I went and I talked to my department chair after some encouragement from my friends in the program. And I told her what happened. And I kid you not, this is not a lie. I wish it was a lie. My department chair said, your advisor just is Italian. What did you expect? And I said, what? And I said, okay, well, can I work with someone else? If I can find another professor in the department that will be my primary advisor for my dissertation, can I switch? And she said, no, you've spent too much time with this person. So either you figure out a way to work through it or you leave. So I left. And for those of you who are in graduate school, particularly those of you who are PhD students, you know that like when you are in grad school, it is your life, it is your job. It's what you've been working toward forever. And so then to walk away, not having completed it felt like the biggest failure of my entire life. Like I hung my head in shame. I felt awful. But thankfully, the research that paid for my living stipend at the time was completely separate from my dissertation work. And that PI was a big champion of mine. And he gave me a job. And he also connected me with some of his former advisees who were at Vanderbilt working in cardiovascular medicine. He gave them my CV. One of them really needed a statistician and gave me a call and offered me a job within like 2 days from a phone interview. And so I picked up and I told my husband, I said, I have a job offer at Vanderbilt. You want to move to Nashville? And he said, I guess. So we moved to Nashville and I worked as a staff statistician for a couple of years. And really through that experience, I was able to kind of like get my footing back under me and realize that I really did want to go back and I wanted to finish my degree. And so I pursued a couple different avenues. I thought that I would join the biostats department at Vanderbilt since that's what I was originally studying. But they said you have to go back to being a full-time student. And I just bought a house. I couldn't afford my mortgage payment on a student salary. And so then I said, that's not going to work. And I asked the epi department, I said, what about you guys? Will you take me? And they said, yeah, and you can keep working. That'll be fine. So that's how I ended up getting a PhD in epidemiology at Vanderbilt. Yeah, it's great. So actually, and now I didn't do a postdoc. I got a tenure track job offer right out of my PhD, and it ended up working out really well. So what I want to let you know after all of this, if you don't know me, but if you are in a place where you do not feel supported, where you feel like maybe this is not the track for you, my email address is on my last slide. You can take it down. You can email me. We can talk. I've been there. I've dropped out. I've come back. So even if you decide that this is not it for you right now, it doesn't mean that you can never come back. Okay. So that's a lot of my time taken up just to let you know it's okay to have a windy journey. Okay. And I'm here for you if you want to talk. So while I was at Vanderbilt, like I said, I worked as a staff statistician. When I was there, I worked with a lot of VA data. I did stuff with Medicare claims data. I worked on the Women's Health Initiative, and I continued my work with the Framingham Heart Study. And so while I was there, we were doing a lot of documentation of disparities, but we were not doing a lot of work to help lessen them. And so that was really kind of like my motivation to go back and finish. It's like, okay, there are research interests of mine that are not being met here. So going back was the way to do that. So what do I study? I study cardiovascular disease. I figure most of you are probably familiar with what cardiovascular disease is, but just in case. So cardiovascular disease, whenever some of it is genetically predisposed, but like a lot of it is lifestyle. So if you're really sedentary, if you have maybe like a bad diet, if you smoke, if you're physically inactive, what that causes is for atherosclerosis or plaque to build up in your arteries. And then if it builds up so that there is a blockage, then or if a little piece of that plaque breaks off and then travels and gets stuck somewhere else in your bloodstream, then that will, if the blockage causes a loss of blood being pumped to your heart, it's a heart attack. If it causes it to not go to your brain, then that is a stroke. So basically the same type of mechanism for a heart attack or a stroke, it's just where it occurs. So that's typically like the main parts of cardiovascular disease. Typically, if you hear about atherosclerotic cardiovascular disease, we're typically talking about strokes and heart attacks. There are other like cardiovascular event phenotypes. So there's heart failure as well. There is PAD, peripheral artery disease, those types of things as well. So my focus is really on cardiovascular health equity. And so I focus on disparities that people may experience as a result of their race, their ethnicity, their sexual orientation, or their gender identity. So what I'm focusing on today is some of my work looking at potential disparities based on race and ethnicity, but I do a lot of work in the VA looking at the cardiovascular health of LGBT veterans, which may or may not continue after what's going on at the federal level, but we'll see. All right, so today I'm going to talk to you about some work that I have done looking at predicting risk of cardiovascular disease. And so I'm going to give you a very brief history of cardiovascular disease risk calculators. So the first CVD risk estimation tools were developed by researchers at the Framingham Heart Study in the early aughts. So much before my time at Framingham, but a lot of the scientists who had kind of developed those calculators were still there. And so I got to kind of work with them. And that's kind of how I got into this space a little bit. The problem with the Framingham Heart Study is that the original cohorts, so the people that were enrolled starting in the 1940s, as well as their children and grandchildren, are almost 100% white middle-class individuals. And so what that means is that the calculators that come out of this cohort are not really generalizable to people who don't fit that mold. So then in the early 2010s, leading physicians and epidemiologists came together and said, we need to do something better. And so they came up with the pooled cohort equations, which are endorsed by both the American Heart Association and the American College of Cardiology. So they pulled data from several longitudinal cardiovascular cohorts to make sex and race-specific risk estimating equations. And so the cohorts that they used were Framingham, which was 100% white, the Eric cohort, which is 25% Black and 75% white, Cardia is 43% Black and 57% white, and CHS, which is 15% Black and 85% white. What you'll notice is that even though there is some diversity in these cohorts, the vast majority of the data that was used was still in non-Hispanic white individuals. And because the derivation cohort only included people who were non-Hispanic white or Black, that's who the calculator is most applicable to. All right. Recently in 2023, the predicting risk of CVD events, or the PREVENT equations, came out. So they pulled data from an EHR system, so something that is like similar to like Kaiser Permanente, but it wasn't Kaiser, as well as some longitudinal cardiovascular cohorts to create sex-specific but race-free risk estimating equations. You may or may not know there's been a really big movement in the last, I'd say 5 years, most prominently, to remove risk or race adjusted anything like risk calculators or formulas within medicine. So one thing that you might know about is EGFR. The calculation has changed. So previously you would calculate someone's estimated glomerular filtration rate, their kidney function basically, from their creatinine, which is a biomarker, but also based on their age, their sex, and their race. And so people who are Black are given a higher value, like it's added to their EGFR. So what it means is that their kidney function would have to be worse so their creatinine level would have to be worse in order for their EGFR value to be equivalent to someone who is identical, but they were white. So it means that Black people would have to be sicker in order to qualify for kidney transplant. All right. So obviously that's not okay. And so that race correction has been taken out of EGFR, and there are other kind of similar tools that are used. And so because of like that kind of backlash, then they said, okay, we need to remove race from these CVD risk prediction tools. All right. So that's one of the reasons that PREVENT came about. The derivation sample for PREVENT was more diverse in that it included Asian individuals and Hispanic individuals, as well as people who did not identify singularly as Asian, Black, Hispanic, or white. But you'll see that 79% of the sample was still non-Hispanic white individuals. Today, I'm going to be focusing on the pooled cohort equations because that's what I have worked with so far. When I talk about next steps for my research, I will be looking at this in the setting of the PREVENT equations, but today we're just focusing on the pooled cohort equations. So this here is the ASCVD Risk Estimator Plus, which is basically the online web app version of the pooled cohort equations. So when you put in your values, what it gives out, your 10-year predicted risk of cardiovascular disease, that is being predicted from the pooled cohort equations. The reason that there are these sex and race specific equations, some of it stems from this data here. So here on the left-hand side, so we'll look at this panel. And we see that this is the average, so that's the predicted risk of cardiovascular disease within 10 years at different ages. And this is in people that are not on antihypertensive treatment in panel A. And so what you can see is that if you look at this as people age, it's stratified by sex and race. And you'll see that there does appear to be a little bit of a differential risk at age 40 when the calculator starts. And so that would be like the difference in an intercept if you're thinking about a regression equation. So in Cox proportional hazards models, there is not an intercept term, but there is the baseline hazard. And so this was their rationale for having differing baseline hazards for cardiovascular disease. And then if you look at the shape of the lines, you'll see that those also differ a little bit by sex and race. And so that is their rationale for having different slopes, basically. So different beta coefficients for each combination of sex and race. Now, when I look at this, yes, I can see that there are some differences in the slope, but if you look really closely, which might be hard given that this is a little bit small, so for African-American men and women, so that would be the red line is men and the orange line is women. You'll see that the lines tend to be, they're not as curvilinear as the ones for non-Hispanic white men and women. And I think that this is potentially a statistical power issue rather than the lack of an actual curvilinear association. Because if we go back and we look at the characteristics of the derivation cohort, you'll see that we had a lot more white individuals, right, than Black individuals. And it takes more data in order to have the statistical power to be able to fit a curve rather than a straight line. Okay. And so I understand that, like, with the limitations of the data, this is why these choices were made. And I've talked with the people who developed these calculators, and they said, like, ideally, we would have things in the calculator that capture the race effect. All right. But at the time that the calculators were developed, that didn't exist. And I think that we're in a new kind of era of data where we have some of that. All right. So the reason that people of color tend to have higher rates and risk of cardiovascular disease than non-Hispanic white individuals are the downstream effects of structural racism. They experience discrimination just because of the color of their skin. Those experiences of discrimination are stressful. Increased stress can increase your inflammatory biomarkers. Those inflammatory biomarkers go on to lead to higher blood pressure, higher total cholesterol, maybe more diabetes. And so those are your primary risk factors for cardiovascular disease. And so it's this stress necessarily that then is the cause for the disparity. And so if we can capture some of these like downstream effects of structural racism and include those in calculators, then maybe we don't adjust for race, or maybe we do adjust for race, but we don't stratify by race. So it's a slightly less intense adjustment for race. Okay. So as a specific example of those different baseline survival rates. So you'll see that for white women, Black women, and white men over a 10-year period, less than 10% of them are expected to have a cardiovascular disease event, where it's a little bit higher for Black men. But then I said that the slopes are different as well. So if we think about diabetes, for white women, for white men, and for Black men, the beta coefficient that's associated with having diabetes is around 0.64 or 65 for all of those groups. And it's significantly higher for Black women at 0.87. And so, again, biologically, it shouldn't matter what the color of your skin is. Having diabetes should confer the same amount of risk, right? Sex specifically. So there's some room for improvement. All right. So as I've said, race itself is not the cause for the disparities. So maybe we should consider including downstream effects of structural racism instead. And in fact, in 2022, there was a paper published by Vossen and Van den Heuvel where they simulated about 30,000 risk factor profiles in both men and in women. And they found that the pooled cohort equations can generate substantially divergent ASCVD risk estimates for identical individuals who differ just by race alone, which is what I demonstrated with the calculator and the example that I gave you. So what this can lead to is that it can lead to overprescription and polypharmacy in Black individuals if we're assigning them a higher risk when they don't necessarily have it. So then prescribing medications, maybe unnecessarily. However, even if that's your argument, if you look at the data, a lot of the data suggests that people of color are actually underprescribed, that the prescription rates are lower than they are for non-Hispanic white individuals, even though they may have higher risk of events. So there's a disconnect that's happening. And so in their discussion, Vossen and Van den Heuvel also suggested replacing the race term with factors that are associated with race, like structural racism, markers of healthcare access, education, economic challenges, etc. So as a recap, the shortcomings of the pooled cohort equations. They have race and sex specific equations. So an improvement would potentially be to eliminate race specific equations and just have sex specific equations. They only include traditional cardiovascular risk factors. So maybe we should additionally adjust for social determinants of health and markers of structural racism. Finally, Hispanic individuals were not included in the derivation cohort, and we should include them. Ideally, we would also include people who are of Asian descent and people who are of other races and ethnicities. Maybe they have mixed heritage. The only problem with that is that we don't have great data for it right now, because ideally what you have is you have baseline covariates for people and you follow them for 10 years or more to see if they develop cardiovascular disease in those 10 years. There are some cohorts that have Asian individuals. So there's the Masala cohort. It started less than 10 years ago, though. So there's not sufficient follow-up. So we're working on kind of solving these problems. There is the Hispanic Community Health Study / Soul Study of Latinos that does have 10 years of follow-up or more on their participants. And so that's what I included so that we have some representation of Hispanic individuals. So the general idea here is to have the traditional cardiovascular risk factors that have been included in prior iterations of risk calculators, add in social determinants of health, and then that should result in more equitable ASCVD risk estimates. So the cohorts that I've included to try and answer this question. So the Framingham Heart Study, I told you earlier that it's almost exclusively white. Starting in the early 2000s, they also included additional cohorts. They have what are called the Omni cohorts, which are multiracial, multi-ethnic. And so in this project, I'm using the Omni 2 cohort, as well as the third generation. So those are the grandchildren of the original cohort participants. Also using data from MESA, so that's the multi-ethnic study of atherosclerosis, CARDIA, coronary artery risk development in young adults, SOUL, HCHS, so Hispanic Community Health Study, study of Latinos, REGARDS, which you all are familiar with, as well as the Jackson Heart Study. So we have multiple races and ethnicities represented in all of the cohorts, except for SOUL is only Hispanic individuals. And then Jackson Heart Study is non-Hispanic Black men and women. But the others have at least white and Black or white and Hispanic individuals in them. Okay. So then the next big question is, okay, well, which social determinants of health do we include? Because there are hundreds, millions of them. So for this project, I was limited to individual level social determinants of health, which were commonly collected across all 6 of the cohorts that I'm including. And I had to go through the harmonization process, because it's not like for employment status, everyone asked it in the exact same way. You know, it's not like there were just categories of full-time employment, part-time employment, retired, student, which I ended up being able to kind of like pull things together in a lot of those groups, but things are not asked in that way across all the studies. And so the process of data harmonization, which I'm not going to go into in depth here, can be daunting, but it also can be done. And it's important when you're pulling data from these different sources. So the things that I was able to capture are marital status, educational attainment, employment status, household income, number of people that are in a household, and whether or not the individual had health insurance. I also wanted to include neighborhood level social determinants of health because I think that where we live and we work is important. And the nice thing about those is that because it's place-based rather than individual-based, each of the cohorts has participants' address of residence. And so then I was able to go and get national level data. So I have area deprivation index, which is built on 17 different dimensions of deprivation based on the American Communities Survey. I also have a measure of neighborhood segregation, which is at the census tract level. So census tracts are used as kind of like a proxy for your neighborhood. And basically what this neighborhood segregation measure is it looks at an individual census tract and it says, okay, what's the racial composition of this census tract? And what is it like relative to everything around it? Are there more white individuals in this census tract than those around it? So that would mean that white individuals are segregated from people of other races or ethnicities, and you can change the focus as well. So you could focus on Hispanic individuals or Black individuals. So saying like, are there more Black individuals in this census tract than those around, and so on. I also had the minimum distance to hospitals. So this is in miles as the crow flies. So it's not taking like actual roads that you would take to drive there, but it's just like looking at, if I lay out a string on a map, what's the distance, as well as the number of hospitals within a 5-mile radius. So for that, I was able to get data from the American Hospital Association that gives me the latitude and longitude of every hospital in the United States that responded. So, I mean, there is some missing data, but it's also pretty good coverage. And so then using a formula basically to calculate the distance between each of those hospitals and where someone lives. So because those are place-based, they were uniformly defined across all of the studies. No harmonization needed. All right, so let's talk about the sample characteristics. So as you can see, I do have more white women than I do have Black or Hispanic/Latino women, but I have fewer white men than I have of Black men or Hispanic men. And so compared to other cohorts that have been used or like pooled sources of data, there is a little bit more of a uniform distribution. All right. So things that the next several slides are going to have a lot of data on them. So I tried to highlight things that I wanted you to see. Basically, age is pretty similar across all of the strata. And traditional cardiovascular risk factors are pretty similar in women. The difference is that white women in my cohort have a lot less prevalence of diabetes than either Black women or Hispanic women. Both of those have about 20% prevalence. For men, total cholesterol is a bit higher in Hispanic men. There are differences in smoking rates. So smoking rates are higher in Black men and Hispanic men compared to non-Hispanic white men. And then same thing that we're seeing with diabetes. So there's a lot more diabetes in men of color than white men. Not going to talk about the cohort membership. It doesn't matter. It's just there for you to know. Now looking at social determinants of health, you'll see that there are a lot more differences. So there's like a lot more color, things to bring your attention to. So you'll see that being married was at least half of the white women and Hispanic women in the sample were married, but it was less than half for Black women, where Black women were more likely to be widowed compared to white or Hispanic women. Education was very different. So the majority of my sample, actually, I said that cohort membership wasn't necessarily that important, but it kind of is in this point. 93% of my Hispanic women are coming from HCHS Soul, as well as 91% of the men, Hispanic men in my sample. And so you'll also see that prevalence of having less than a high school education is much higher in Hispanic women and men compared to both white and Black men and women. And so that's something to keep in mind as we're talking about results. So then that kind of like trickles down to the difference in the proportion of people that have a bachelor's degree or a graduate degree. You'll also see that, interestingly, so 75% of Hispanic women reported being a homemaker, compared to 11% or less in white or Black women. And that also almost 18% of Hispanic men said that they were homemakers, compared to less than 1% of Black and white men. You'll see that obviously because of that, the proportions for part-time and full-time employment are different as well. Only 2% of Hispanic women reported being retired. So there is a little bit of an age difference where the Hispanic women in my sample are a little bit younger, but not a ton. Same thing for men. You'll also see that there are very big differences in income, where household income is much higher in non-Hispanic white men and women compared to either group of color, particularly compared to Hispanic men and women. Health insurance coverage is also much lower in Hispanic individuals than other groups. Area deprivation index, I thought this one was really interesting. So as the area deprivation index increases, that means the deprivation is greater. So we actually see the lowest level of deprivation for Hispanic men and women compared to white or Black men and women, and that the area deprivation index is greatest for Black men and women. We'll see that neighborhood segregation. This one is a little bit harder to interpret because it's a Z-score, and it is in reference to white individuals. Basically, the one thing that I want you to take away from this is that white people are a lot more likely to live in an area surrounded by a lot of other white people than Black or Hispanic individuals. So white people tend to segregate themselves, which goes along with, historical systems of power. And then number of hospitals. So you'll see that the median number of hospitals in a 5-mile radius of people who are Hispanic is 12. So these are people who are living largely in urban centers where there are a lot of healthcare, a lot of hospitals around them, basically. So that's kind of a distinguishing feature to think about as well, which also likely results in the area deprivation index being lower. So these are people who are in cities who have a little bit more access to things. All right. So for the statistical models, I use Cox proportional hazards regression to assess the association of social determinant of health variables with ASCVD risk in a model that was already adjusted for traditional risk factors. So what this lets us know is in a model that already adjusts for things that we know are associated with CVD, are the social determinants of health associated. And then I had separate models for each combination of sex and race because that's the way that the pooled cohort equations were developed. And that therefore groups Hispanic and white individuals together. So that is what I did. And then I did separate models for each social determinant of health. So when we look at these, keep in mind that's the only SDOH that's included because I wanted to avoid issues of multicollinearity. After that, I added groups of social determinants of health. So individual level SDOH, neighborhood level. Then I did all of them together. And finally, stratum specific. So whatever I saw was significant in the individual models, just making stratum specific models. So I looked at the incremental value. So this is like, how does the model performance at predicting who's going to have a cardiovascular event improve? And so the statistics for that, I looked at a likelihood ratio test to look at goodness of fit, change in the C statistic, net reclassification improvement. So do people move across risk categories and the Relative Integrated Discrimination Improvement, the RIDI, which basically says, are we able to move people across the risk spectrum? What's causing these results? This seems weird. Could it potentially be the Hispanic paradox? If you've never heard of this, basically it posits that despite having higher prevalence of cardiovascular risk factors and generally lower socioeconomic status, Hispanic individuals have lower incidence of cardiovascular events. Whether this paradox actually exists is pretty hotly debated, but some of the reasons that they say that it may exist are the healthy migrant hypothesis. So people who are migrating to the US may tend to be healthier than those who are staying in their home countries because they're well enough to travel. There's also something that's called the salmon bias hypothesis. So basically, you know, salmon will migrate back to where they're from, which is basically what it's saying here is that like whenever individuals get older and they start to become more sick, then they go back home so that they can be closer to their families. It could also be because of social and family support, which tends to be quite a bit higher in Hispanic families. It's more highly valued. It's more likely that you'll see multi-generational families living in the same home when compared to non-Hispanic white individuals, as well as diet. There's a lot more legumes, so beans that are eaten in a lot of Hispanic cultures than in non-Hispanic white. So it could be any of those things. So what's the takeaway from all of this? The set of social determinant of health variables that are associated with CVD in a model which already adjusts for traditional CVD factors differs by sex and race or ethnicity. So what this means is that if we are adding social determinant of health variables to a sex-specific but race-free calculator, this could lead to misestimation of risk for some or all groups. So for example, if we added education to a race-free model predicting CVD events in women, what we might do is we might overestimate risk in highly educated Black women because we have more white and Hispanic women than we do Black women. And so the beta coefficient is going to be pulled toward that larger sample, right? And so we might be misestimating risk. But if we also think about education and we think about how those hazard ratios were kind of in opposite directions for most of the groups, if we add in education to this race-free calculator, we might not see any association between education and CVD risk at all. We might completely negate the association. So we found that out. And then also not only did those associations differ by race and ethnicity, but there was a differential impact on the model's predictive power when including various sets of social determinants of health. So basically there's no cut and dry answer to this. And what that means is that maybe a race-free calculator that just blanket includes social determinant of health variables could potentially exacerbate disparities rather than help to improve them. And so, you know, like I said, there's been this movement away from including race in a lot of medical calculations, and for good reason. I do think that there is, however, a difference in your objectives. So I think that going back to that example of EGFR, you're penalizing people for not being white. You're making them be sicker in order to qualify for kidney transplant. Whereas when we're talking about risk prediction, what we're really trying to do is we're trying to determine who is the group of people that are most likely to have an event in the next 10 years, and what can we do to make sure that that doesn't happen. So if we are able to do a better job of figuring out who's at greatest risk by including race and potentially having some interactions between race and social determinants of health, that might be a solution. I think that it does make sense to not have the biologic variables, so things like blood pressure, like cholesterol. There shouldn't be a reason for those things to vary by race. The color of your skin does not matter what a 5 millimeter of mercury increase in systolic blood pressure does to your risk. However, the area that you have lived in and your lived experiences are going to matter differently based on how you have experienced them. And so I think that there is potentially a place for those interactions between social determinants of health and race, but I don't think they should exist for biologic variables. Some strengths and weaknesses of this analysis. Some strengths are that we did have a large and diverse cohort that was created from pooling data from 6 different cohorts. We did harmonize individual SDOH variables and uniformly define the neighborhood SDOH. However, the limitations are worth noting as well. So I didn't have data on experiences of discrimination. I think that's really important. I don't have anything on food insecurity, policing, or redlining. If I could find national databases that had validated measures of policing and redlining, I would really strongly consider including them. Although I gotta say, getting additional data from 6 different cohorts and going through 6 different processes, 6 sets of contract negotiations every time I need an additional variable is rough. So maybe not. It's also unclear whether the lack of significant results that we saw in Black men is actually due to a true lack of association or insufficient statistical power, because that was my smallest group that I had. I'm also wondering if some of these variables that we don't have would be more meaningful for Black men. And then the initial pooling that I did of white and Hispanic individuals, it does overlook the discrimination that's faced by Hispanic people. And so it may obscure some important differences by group. So what are the next steps? I want to rerun the incremental effect analyses where I have non-Hispanic white and Hispanic individuals disaggregated the way that I did for the original Cox models. And then, like I mentioned, I want to consider models that adjust for Hispanic ethnicity in those like white Hispanic models and have interactions between ethnicity and social determinant variables. I'm presenting at AHA Epi in March, so if you're going to that meeting, you should come see me. I'm giving an oral presentation on Sunday morning. And then once I wrap this up with pooled cohort equations, I'm going to do it all again in Prevent. That's it. Thank you.